Good morning, everyone, and thank you for joining us for today's webinar titled COVID-19 Planning Considerations from a Public Health Perspective, which will cover issues for law firms and other businesses to consider as they plan their reopening. If you'd like to pose questions, you can do so by typing them into the YouTube chat channel on your screen or email them to crisel@msba.org, the email address you see at the bottom of your screen. Our MSBA president, Dana Williams, heard today's speaker present last week and felt the information was important enough for all of the legal and business community to hear. And he's joining us this morning to share why and to introduce our speaker. President Williams.
Good morning, everybody, and welcome. Thank you for participating in this event. I'd like to introduce Trudy Henson, who is the Public Health Program Director at the University of Maryland Center for Health and Homeland Security. That organization is a nonprofit consulting group and academic center committed to maximizing organizational resilience before, during, and after an emergency event, which I would say is pretty poignant to what's going on today. Ms. Henson has been at the center for approximately 10 years. She is the program director there. Her experience typically focuses on legal and policy responses, plans needed to reopen from man-made disasters to Ebola to seasonal flu. She has written about mass fatality planning and legal considerations and helped develop one of the first alternative care site plans of its kind. She also has conducted numerous state legal surveys to gap analysis. Ms. Henson is a Bachelor in Arts from Berry College, a Master in Arts of English Literature from the University of Georgia, and graduated cum laude from University of Maryland Francis King Carey School of Law in 2008. She is also an adjunct professor at Maryland Carey Law, where she teaches law and policy of emergency health response. I have a number of other things that she's participated in, but that I think gets you the gist of her bio. So welcome, Ms. Henson, and thank you very much.
Thank you, President Williams, and thank you, Andrea Terry, and I want to thank Bill Hall and Crisel Anderson for helping us pull this together. And then, of course, I want to thank everyone for participating in this webinar and for listening. We are going to kind of keep it high level today, and we're going to talk about the COVID-19 outbreak and what we know, what we don't know, and some planning considerations. So if we can go to the next slide, we have a very simple overview. And again, we'll talk about what we know, what we don't know, and the implications of that for planning. And we have a picture of our friend, the coronavirus there. One of the questions that I've gotten, and I'm sure you all have read this, is why is it called a coronavirus? It's corona is Latin for crown, so the virus kind of looks like a crown, and that's why coronavirus. So if you want to go to the next slide, once we're done with this, if you have questions, I'll be happy to take them. So let's start with what we do know. The SARS-CoV-2, which is the virus that causes COVID-19, can live on surfaces from 4 to 72 hours, possibly longer, and it depends on the type of surface. So for copper surfaces, for example, the virus only lives 4 hours. On cardboard, we know it lives 24 hours approximately. On plastic and hard surfaces, we've seen that it can live 72 hours. In lab conditions, it can actually live longer on some of those surfaces. We know that the virus can stay in the air through aerosolized droplets, such as talking, coughing, or sneezing, as I'm sure you've heard, and it can stay in the air for up to 3 hours. There is a potential for transmission when those aerosolized droplets are in the air if someone else walks through, breathes those droplets in, and it gets into their respiratory system. We know that the virus can travel on air currents, and that depends on the temperature, the humidity of the air, and all of these small differences can affect the recommendations for social distancing. So the number that we keep hearing for physical distancing with businesses and other places is 6 feet. But public health epidemiologists and other medical experts have done modeling that shows sneezing and coughing and sometimes even talking when you're loud or shouting can actually project those aerosolized droplets up to 9 feet into the air. Some studies of air currents, especially for exercise, outside because of wind and the way aerodynamics, if people are running, suggests that the distance that you keep should be even further, so somewhere between 15 to 50 feet. And at least one study of an infection outbreak in China from a patron that was dining at a restaurant showed that the patrons that were also infected by that patron were infected by the airflow in the restaurant based on the AC system. So there was a patient that was sitting at a table, and 9 of the customers around that person got sick, and the outbreak or the transmission followed the air current from the air conditioning unit. Next slide. So we also know that the virus can be transmitted from asymptomatic people, and this is incredibly important when you start thinking about your planning considerations, because we know that most of the cases for COVID-19 are asymptomatic, although the lack of widespread testing has made this very difficult to prove. So even in cases where patients become symptomatic, so they may be asymptomatic or what some people call pre-symptomatic, the virus can be transmitted prior to the onset of symptoms. So even if you later become sick, you can transmit the virus, most studies and literature currently suggest, prior to you having any symptoms. So one study found that people's viral load, which is the amount of the numbers of virus that you have in your body, is higher 24 hours, approximately 24 hours prior to the onset of symptoms, which means that when the person is kind of at their best ability to pass on the virus, they are exhibiting no symptoms whatsoever, don't feel weird, don't have a temperature, none of that. A new study out in Nature journal found that in Singapore and in one city in China, approximately half of the COVID-19 transmissions occurred pre-symptomatically. So people were feeling fine. And then because those Singapore and China had very tight monitoring and contact tracing, they were able to figure out that half of the cases came from people who were pre-symptomatic who later became sick. Next slide. We know that COVID-19 affects those who are most vulnerable, and we know that those have tended to be people who are over 60 to 65, immunocompromised. It seems to affect males differently than females, so we're seeing more deaths from males. And we know that it has been particularly devastating for people that have been smokers or are current smokers. And we also know that people who have pre-existing conditions are particularly vulnerable. And a lot of discussion has been given to those pre-existing conditions. So we hear about the smoking, we hear about lung disease and heart disease, but I want to take a minute to also underline some of those other pre-existing conditions, because we're starting to hear more about them now, but we don't hear as much about them. And that includes hypertension, so high blood pressure, people with diabetes and obesity. And in the United States in 2018, approximately 34 million people had diabetes. 88 million had been diagnosed with prediabetes, and about 42% of the population was medically considered obese. So when we're talking about pre-existing conditions, we're not necessarily talking about small subsets of the population. You know, that statistic for diabetes is about 10% of the population. And when you combine those with some of the other pre-existing conditions, all of these people are at an increased risk for COVID-19 and having complications from COVID-19. And then, of course, you hear about lung disease, but that also includes people with asthma, and that's a very large subset of the population as well. And then, not to get too heavy on a Monday, there is literature that suggests that even those that are the healthy young, so people in their 30s and 40s, are dying from clots, from strokes. And these are people that had no indications, no risk of strokes. They were healthy, athletic, in shape people with no prior pre-existing conditions. And the medical community is not sure what's causing these people to have the clots and the strokes, because they are generally healthy people, but they are experiencing severe side effects from COVID-19. Next slide. So just to sort of summarize, this is a very nasty virus, and it's already stressed our medical systems. It's stressed our healthcare workers, our supply chains, our economy. It has been a true global pandemic, and it's affected every aspect of our modern lives. And that doesn't include the families and the individuals it has affected either through illness or death or economically. There's just sort of a cascading effect of this virus. And there are downstream effects of the virus that we haven't been able to fully focus on yet. You're starting to see some of those conversations occurring, especially now as people are looking at how do we reopen, how do we think about a new normal. But there's all kinds of medical procedures, people who are dependent on certain medical access on a regular basis for chronic diseases. All of those have been kind of pushed aside. There's a mental health component I'll talk about in a minute as well. And all of those we have not been able to turn our focus to because our focus has been on the response, and rightly so. But again, it's just something to keep in the back of your mind as you're thinking about the reopening. So let's talk briefly about what we don't know. If we can go to the next slide. And again, I don't want to overwhelm people. We know a tremendous amount about a virus that we did not even know existed about 5 months ago. And that is amazing to see. But again, when you're thinking about these planning considerations, it's important to have this information. So it goes without saying, but we don't know how to treat COVID-19, and we don't know when we'll have a treatment or a vaccine. So what we're seeing is what I would call a kind of three-prong attack on the virus. And the first is a therapeutic attack. So how do we help the people that are already sick with the virus? How can we help their system fight the virus? What supportive care can we give them? Is there any medicine that helps them fight the virus? And so one of the things that we're hearing a lot about is remdesivir, which is an antiviral used for HIV. And that just received this last week emergency use authorization approval from the FDA in use with patients who have COVID-19. And that study, which was done, again, all of this is being done very quickly, found that remdesivir could shorten the length of the virus for patients that had it. It didn't necessarily cut down on the severity or the fatality rates that they found so far, but it was enough clinical findings that the FDA approved it. We also heard about hydroxychloroquine, which is the drug that is used for lupus and other immunocompromised diseases. And there has been some medical literature that has suggested that's been successful. There was a study out of France with doctors that said that they had seen that it helped improve their patients. That's not something that we've seen a lot of proof of in the United States. And then we've also seen discussion of azithromycin, which is an antibiotic, combined with high doses of vitamin C. So all of those are to help people who are already sick, help their systems fight the virus, and give them supportive care as they are sick. The second prong is vaccines, and we're hearing a lot about this. This past week, Anthony Fauci with the HHS and the National Allergy and Infectious Disease Agency was saying, they've started what they're calling Operation Warp Speed to create this vaccine. Drug companies, countries across the globe are working on creating the vaccine. They're moving at lightning speed. They already have some vaccines that are in a trial phase. Now, vaccines typically take about 10 years to develop. So we're talking about a vaccine that's being developed for a virus that we didn't know existed 5 months ago. So again, really moving at high speed. But nonetheless, Anthony Fauci said January 2021 is likely the earliest we'll see a vaccine if things fall in the right place. So once we have a vaccine, once we know it's safe, once we know it's effective against the virus, we then have to scale up production, and that can be a very large component of the time that it takes to manufacture the vaccines. Again, because the nature of this virus, we will likely see a high demand for the vaccine once it exists, and the FDA and HHS will likely create vaccine schedules prioritizing people who can get the vaccine first. So if there is short supply, it will be limited to certain high priority people based on their risk, most likely. That's what we've seen in prior pandemics. And again, we're talking January 2021. So very quick for a vaccine, but for those of us that are in the middle of this, that seems like a long way off, especially when we kind of just want to go back to, quote, normal. The third prong of what we're seeing is what I call herd immunity. And so this is kind of the inevitable movement as the virus spreads. People are getting it. They may know they have it. They may not know they have it. And as more and more people get it, it becomes more difficult to spread because people have immunity, we think. So that's kind of the third prong of that, and that just happens, as the course of the virus goes along. We also obviously don't know how many people have had the virus. We have limited testing, very limited testing, too limited testing to really know these numbers. But public health experts and medical experts have estimated that probably about 3% of the US population has had the virus so far. Different pockets will have higher numbers, but on average. And we also don't know what it takes to achieve herd immunity. And this is a very big question. And it goes hand in hand with the testing. So when we talk about testing, one of the benchmarks that Maryland specifically has set out is that they want to try to keep the percentage of positive COVID-19 tests to about 10% of however many people they're testing. They don't, the public health experts agree that if the number is higher than 10%, you're probably not doing enough testing to catch pockets of outbreaks. So if you're testing 100 people, you want it to only be 10% that are testing positive. So 10 people. In Maryland, as of last week, we were at about 18% of people testing positive. Maryland has made some really big steps in acquiring tests that will help us get those numbers, get more widespread testing, and that has been really great to know. But again, one of the big questions is, what does it take to reach herd immunity? And that's one of the big unknowns. The idea is that the virus will still transmit, but people will be more protected. It won't overwhelm the health systems, and we kind of have flattened the curve. So one of the numbers that we hear for herd immunity with COVID-19 is we need about 60% of the population to have had COVID-19. That's a guess based on some modeling and research that people have done, but it is still a guess. And for a lot of viruses and diseases, for example, measles, for herd immunity to be effective, you need to have about 95% of your population that have either been vaccinated or already had the disease. So 60% is lower than that, but when you consider that we're looking at what we think is an average of about 3 to 4% of the US population having already had COVID-19, we're still quite a ways from 60% if that is, in fact, the magic number. And we also don't know whether having the virus creates long-lasting immunity or short-term immunity, or if you can actually get the virus again and get ill again. And that's something that researchers are working very hard on finding out. There have been some cases where medical professionals have had people that tested positive for the virus, were ill, tested negative, have gone some length of time with a couple of negative tests and tested positive again. It's unclear if those people just still have the virus in their body but can't transmit it, if they're actually going to fall sick again, or what that means. So that's one of the questions. We don't know if COVID-19 is something that you get once, like chickenpox, and you never really have it again, or if it's something more like seasonal flu where you can get it, once and you're okay for 6 weeks, 8 weeks, 6 months, but then, next year you might need another vaccine. Next slide. So we don't know, I talked a little bit about this, we don't know whether the virus that survives on surfaces or in air for extended periods of time can transmit the disease. So we know that we can find pieces of the virus on surfaces. They found it on cruise ships up to 2 weeks after people had been off the cruise ships. They have found it in air for longer than 3 hours, but it's not clear if the virus is actually able to transmit at that point, or if it is so degraded that it can't transmit the disease. That obviously has a tremendous impact when you're thinking about your planning considerations for reopening. And then we also, like I said, don't know whether individuals who have had the virus can be reinfected and what that reinfection looked like. Do you have some protection? Is the virus less severe if you've had it before? Are you one of those people who then has it but doesn't have any symptoms and is asymptomatic. That's just something that we don't know. Next slide. So again, one of the reasons that I mention all of these things is that this has big implications for planning. Epidemiologists agree that this virus is going to be with us for a long time. And, we're looking at January for a vaccine. There is some discussion of possibly fall or winter for a vaccine. Again, that would be, everything has to fall into place and just move at an incredible speed. So when you're thinking about reopening your business or thinking about how you're going to return to a physical presence with your business or organization, you're planning for longer term. You're looking at a year to a year and a half, and it's a very fluid situation. We have phased reopenings, and Maryland put out its roadmap to recovery about a week and a half ago. The federal government has put out its roadmap to recovery. All of these are predicated on decreases in positive cases. So the federal standard for reopening and its guidance, the guidance recommends 2 weeks of decrease in cases. And that's also something that the state of Maryland has said, that any reopening is predicated on a 2-week trend of decrease in cases. And then even once things have reopened and phased, states, any spikes in cases can result in targeted stay-at-home orders or limited closures of buildings or businesses, or widespread closures in likely geographically limited areas. So again, this is important because reopening will be in fits and starts. It's not going to be what I call a game on situation where we say, okay, we're back, and we just start back running. I was speaking with someone in public health, and they were saying, it's almost a disservice to say a new normal, because it's just new what we'll be seeing and what we'll be doing. Next slide. Again, for planning purposes, epidemiologists are pretty much in agreement, and Dr. Redfield from the CDC was one of the first people to put this out here, that a second wave of COVID-19 is likely, and they are predicting that that's going to coincide with our typical seasonal flu season in the fall. So the reason I mention this is, number one, something to think about when you're looking at your timelines and your planning, but also as an organization or business, to the extent that you can encourage seasonal flu shots for your employees, that's a great incentive because we don't want to have to be worrying about seasonal flu along with a second wave of COVID-19. So if you're an organization or business that partners with healthcare places to make the flu shot free, or that comes to your workspace, again, that's something that you want to look into and think about earlier rather than later. Because of this worry about second wave and the coincidence with the seasonal flu, it's likely that the demand for the seasonal flu shot will be higher. So there may be, that demand might affect what is available. Another thing to consider is the need to reduce transmission in the workplace, and I have some specifics on the next slide, but another thing that you hear a lot about now is the reduction of people's exposure through their bubbles. Who are they in contact with? Who do they live with? Who do those people get into contact with? And how can you kind of create bubbles in the workplace? So one of the things that we're hearing about is fixed staggering scheduling. So, you're talking about some people coming in on Monday, some people coming in on Wednesdays, some people coming in on Fridays, and other people coming in on Tuesdays and Thursdays. But trying to make sure that those people have their own workspace bubble, so that if a worker who comes in on Mondays and Wednesdays tests positive for COVID-19, your contact tracing and your notification process is easier. That person was in the office with 7 other people. You tell those 7 other people, we have a presumptive case or a positive case of COVID-19, and then you put your policies into effect from there. Next slide. So again, when you're thinking generally about your policies for returning, they should contemplate a variety of scenarios. So there's almost endless permutations for how this can happen. Employees who test positive for COVID-19 versus employees who have exposure to a known case of COVID-19? Are you going to handle that differently or the same? Are you going to have a standard for returning to work after a positive or a presumptive case? Is that standard going to vary? So if it's a presumptive case of COVID-19, the person was sick, but did not test positive for COVID-19, are they staying home for 14 days and then 3 days without symptoms? What is the point at which they're allowed to return? If it's a positive case, is that standard for return to work different? And then again, what are you going to ask of your employees if there's a potential that those employees were exposed at the workplace? And then how to trace and quarantine workers within that bubble. Again, the policies that you can think about now will really help you in the future. We have time. A lot of us have time to really be thinking through this. And now is the time to do that. Consider how physical distancing affects your building space, your office, your parking, your commute, etc. It really requires sort of a wholesale top to bottom evaluation of your business or organization, thinking about how your desks are laid out, thinking about the flow of your office. I was part of a different conversation and someone was talking, she works with a lot of law firms, and she was saying firms in urban settings are really having to consider this because people in high-rise buildings, elevators that used to hold 15 to 20 people now for physical distancing reasons can only hold 2 people. So how do you get your people up to their floors? Is that something that you think is worth the time to do? And how do you do that? What does the lobby look like? Are you going to have a one-way flow into and out of your building? People that take mass transportation into the office, again, it's going to be a very different ballgame when physical distancing is implemented on subway cars, on buses. It's going to slow everything down tremendously if everyone is trying to get back into major city centers that way. And the ridership is in a half or quarter because of the physical distancing requirements. Next slide. So one of the things to think about is creating a safety culture when you do decide to have employees return to work at your organization or business. And these are some very general recommendations. We're seeing a lot that masks are really recommended because of that aerosolized droplet contagion and possibility of transmission. And that is for employees, and also you really want to think about whether you're going to require clients or visitors to wear masks. And are you going to provide them, or are you going to ask them to bring them in? Are people going to be turned away if they don't have masks? And if they are required to have masks, making sure that that becomes part of any communications with clients before they come into the office. Keeping at least six feet physical distance. Depending on your office setup, that may be more or less difficult. A lot of offices have, and even in grocery stores, we've seen sort of those plastic sneeze guards, as they're called, being put up where 6 feet is difficult to implement. Cutting down on your shared social areas, so office kitchens, office coffee makers, office water coolers, all of those kinds of things. Any areas where people sit and take their coffee breaks, you're actually going to want to discourage the use of those, because again, those are areas that need to be deep cleaned. You might want to repurpose those spaces for desks, because you might be reorganizing your office. If you can, increasing the deep cleaning and disinfection that's happening at your office as frequently as possible, ideally overnight, especially if you're doing a staggered schedule for employees that are coming in. You want to make hand sanitizer and wipes available at high touch surfaces. So any touch screens that you have, any counters that you have, tables for conference rooms. These are supplies that are in high demand and difficult to get. So it's a difficult recommendation to implement. And then another recommendation is looking at your doors. They make kick plates, and some restaurants have these now, but there's a pull thing that you can get that goes on the bottom of the door, so you can actually pull the door open with your foot rather than your hands. And all of those things can actually cut down on the surfaces that you touch. It can cut down on the possibility of transmission. And then this is not going to be a popular job, but you might want to consider making some people in your office what I'm calling safety officers. So people that kind of go around and make sure that the employees are actually following and enforcing those safety rules. We have probably all driven by grocery stores or pharmacies where you see people that are employees and they have the masks and they're wearing them right here around their neck and they're out back talking to each other with them off. So that's the kind of situation that you want to try and avoid, and safety officers can help with that. Next slide. So again, when you're thinking about these things, it's really important to remember, and I think to understand and work with employees who are medically vulnerable or those who live with people who are, because this is a game changer for those people. They're going to have a very different outlook. And even people who want to return to the office, you need to be prepared that those people, once they actually physically return, may not want to be there. They may want to be there, or they may think they want to be there and get there and be deeply affected by this new work environment. I know for a lot of us, our office is kind of our safe space away from home. Our coworkers are the people that we're excited to see. They're kind of our second family. And a lot of these new recommendations and guidelines, when implemented, is going to change that environment in ways that people may find unexpected or that they are not really prepared to deal with. And so that's something else that you want to keep in mind as you're talking through these things. Next slide. So my final kind of area for consideration is the mental health component of the pandemic. It's not clear. I've spoken with some mental health professionals and they've said, I said, are you just getting, request after request for new clients? And they said, we're actually not, which is surprising because the clients that we, our existing clients are not doing well. So they kind of expect this, a lot of new patients coming in. There's a lot of reasons that may not be happening, from limited resources to not being able to find people that can take them in. But again, I think there's the impact of the pandemic and the social distancing that we're seeing. And then we're also going to see the impact of this new normal that's going to affect individuals, I think, in some unpredictable ways. And again, that does not include those people who have been personally affected by the virus through illness or death. And so one of the recommendations I have is to really make mental health part of your policy and planning considerations. I know a lot of businesses and organizations have done this throughout and have gotten a lot more proactive about incorporating these messages into their general communications, but make sure that your organization or business is reminding your employees of the mental health benefits that are available to them, if there are hotlines, if there are services or support that's available to employees, making sure that that's a part of your communications, just so that those employees know that there is support out there and that they can access it. Next slide. So that is really all that I have to say. I just want to reinforce that in the 5 short months since we've learned about SARS-CoV-2, we've actually learned a lot about it, and we're seeing some incredible acts of ingenuity and research and information sharing and innovation. And I think that, is something that we really need to focus on. Again, the message is there's still a lot that we just don't know, and we can't discount the impact that those gaps have on our planning. And so that when we're able to reopen, the more that we can contemplate those things prior to the reopening, the better able we are to protect our employees, our customers, our clients, our families, and ourselves. My contact information is on the screen. So if you have questions that you would like to ask me afterwards, I'm happy to do that. But I know that President Williams and Andrea Terry have slated for a lot of questions, time for questions as well. So if you have questions, please feel free to ask those. So one of the questions that we've received asks if you could talk a little bit more about the other factors that Governor Hogan is looking at for getting to phase 1 and those 2 weeks of decreased cases, hospitalizations. So is it an overall 2-week downward trend, or is it any day that bumps back up to reset the 2 weeks? And that's a really great question. I believe that that is kind of unanswered, but I think the idea is an overall 2-week trend downward. If there is a spike, I think there will be some consideration given to, where is this spike occurring? Is this spike occurring in an area that is just getting access to testing? Is this spike occurring in a pocket that we can reasonably understand as, nursing homes and long-term care facilities are one place that we're seeing sort of a tremendous explosion of cases, but they're fairly isolated. So I think all of those questions would affect that 2-week downward trend. One of the other, I won't say benefits, but one of the things that Maryland is going to have that other states don't have is because we are not yet reopening, and some states starting last week started reopening, we're going to have the benefit of seeing how those states, how their policies are playing out, what the impact is, if they're seeing increases in cases. So Georgia, Florida, Tennessee, those states have reopened various businesses. And so I think there's a lot, if we're watching those things, that we can see and possibly learn from. We're getting another question about widespread testing and if we know when that will be available in Maryland. As many of you likely know, Governor Hogan and his wife procured 50,000 kits for testing, which can actually be used to test about 500,000 people. And the question is, when will those tests be made available? I don't know the specific timeline on those. I know there's distribution. I think we're going to see that increasing a lot in the next week or two because the kits come, it's 50,000 kits, and then they're divided up with different, mediums and things that they use for the testing. So I think we'll see that really stepping up in the next week or two. And again, that's an important part of reopening. And I think one of the things that we're seeing in Maryland is Governor Hogan has taken that aspect of it really seriously. And that's been a consistent recommendation at the federal and at the state level from public health officials and epidemiologists is it's very hard to open or to consider the impact of the virus when the testing is not as widespread. So the sooner we get that widespread testing, the better information we'll have. And that can definitely impact our policies. Are there other questions?
Okay, we'll give the audience one last opportunity to post questions. In the meantime, we'd really like to thank Trudy for sharing all this important information. President Williams.
Thank you so much, Ms. Henson. This is great, and I think that our members will get a lot out of this information. Will be helpful to them going forward. And I thank you for your time and your expertise. Thank you so much.
Thank you.
All right, thank you, President Williams. Thank you, Ms. Henson, for coordinating today's presentation. This will be available on our website. If you had colleagues who weren't able to join us this morning, we hope everyone finds these timely presentations by the MSBA to be helpful. Please keep us informed if you have any other topics you'd like to have covered. With that, we'll close today's program. Take care, everyone.
Thanks again.